Hi, I'm Brad Power, and this is the Prostate Cancer Lab. We're honored to have Kerri with us today. Kerri, let's see now, how did I meet Kerri? So it was through Kathy Spinner, who was with Judy. Is it Judy? Am I remembering?
I think it was Kathy Skinner to Katie Schmitz.
Katie, that's what I
back to me.
Right, it's because a lot of people have had interest in exercise as a approach to if you're taking androgen deprivation therapy, keeping your muscles in shape, generally around resilience, musculoskeletal strength, and just, being generally healthy and having a strong immune system. So everybody's interested in exercise, particularly anyone who's on hormone deprivation therapy. So we started looking around for some experts, and Kerri is not only an expert, but also has some clinical trials. So there's an opportunity to potentially participate in some of the things that she's got going. So it's a twofer here with Kerri. Kerri's at OHSU. I'm sure she'll introduce herself. So the disclaimer here, as usual, I think all of you have heard it before, but just to stay with the formality with which we're trying to be responsible is, of course, this is not medical advice. If you need medical advice, consult with your medical team. And the other thing is that everything that we say on this forum will be recorded and will be made public. So if you're concerned about going public with anything that you say, don't say it. You can turn off your video and put a strange name so that we don't know who is on the screen. But otherwise, everything you can expect, everything we say will be made public. However, everything, and this is for Kerri's benefit too, but everything that is said by anybody I will run by everyone so they have an opportunity to edit before it goes public. And with that, I'll turn it over to Kerri.
Okay, thanks, Brad. Thanks for the invitation. I'm was excited to come and talk to all of you, and excited to learn more from Brad about your group and what you're aiming to do, and how I could potentially be helpful in that respect. So let me share my screen. Brad said, prepare a couple of slides. Well, you say that to an academic. It's like, I'll take my slide deck of 45 down to 10. So I have something that I do hope will just kind of walk you through who I am and my research program. I would love to get a little bit more in depth, but I know this isn't quite the forum for that quite yet. So glad to do so when we get to the discussion time. Can you see my slide? And a picture? Yeah.
Yeah, and if you would click on that in the bottom right if you click on that thing that looks like a screen, I think you'll get the full screen mode.
Oh, it should be in full screen mode. Okay. It's not for you?
Correct, it is not. We're seeing the wonders of Microsoft PowerPoint.
Is this better?
Not yet. No, it's the one that's a bit to the right of that one. It looks like a
But for me, I'm in slide mode.
okay.
So I'm not quite sure.
If you have a dual monitor, maybe we are seeing your different monitor.
No, I just unplugged it. Good idea though. Because I was worried about that.
Well,
right, let's try it again.
We can see it fine. It's just that it's not full screen.
Still not full screen.
Correct.
Oh, you can increase the size by moving the slider to the right. You see how it's at 94%, and that way at least it will take more of the space on the screen. On your end, on the bottom right, there is a slider that says what is the zoom size on the bottom right of your PowerPoint, in case you cannot present.
Yeah, I don't have that on mine. Let me try again.
I think you're seeing the presenter mode.
When you were showing these slides, it's fine. I think I can view it perfectly. Can everybody else see it? I can see it fine.
Yeah,
it was fine. Just go with it.
All right, just a second. Now I got to pull it back up again. All right, hang on.
And as a dual benefit, I can verify it's actually Microsoft PowerPoint.
All right, hang on, guys. Sorry about that. are we full screen?
Yes, yes.
Hey, my apologies. So, as Brad mentioned, most of my work is really, well, a lot of my work is focused kind of more broadly on exercise oncology, but I'd say probably 50% of the work that I've done since moving into this field has been in prostate cancer, and specifically on using exercise as a countermeasure to ADT. So hopefully I'll be able to provide you with some helpful information today. But I thought I'd start by just giving you a little bit of an idea of who I am and how I got into exercise oncology. So I started out at UC Davis. I heard someone was from the SAC area. I started out in California, and I am a human performance major. So this is a field that may be unfamiliar to some people, but it's the more sophisticated version of physical education. And it was really where we moved the field toward using exercise to study how to make people stronger and faster and more competitive, and harnessing that those adaptations that happen from exercise training and using it to actually help either prevent disease in the first place or to help manage disease once somebody has it, either by controlling disease or managing the side effects. So I did my PhD at Oregon State University down in Corvallis, also in human performance. And at that time, I moved from working with athletes to working with women to use exercise as a way to prevent osteoporosis. My work was actually funded by NASA because they were looking for ways to use some of the research that was being applied to prevent bone loss when people go up into zero gravity to actually benefit the general public. So some of my work was funded through that mechanism. And what we were really trying to do was figure out what are the training principles and the ways that we can manipulate exercise to preserve bone due to deconditioning or due to aging and hormone changes. So in my work down at OSU, we actually used athletes as a model. And what we tried to do is characterize the bone strength across different types of athletes and figure out what is it about the athletes who have really high bone density and their training regimens that we could harness in a way that we could use it as either a preventive strategy or a treatment strategy to address bone health in people back in 1G environments. So that really is kind of the principle of the work that I do, is around this kind of training concept called specificity. So how do we kind of take some specific principles around exercise training, around different exercise modalities, and then manipulate that in a way that can treat human health. So when I came to OHSU, I used a lot of that work to start addressing problems that people were incurring because of their treatment for cancer. And that started with some work in prostate cancer, where we were using kind of these bone loading programs that we developed to see whether or not they could be effective at preventing bone loss that was associated with hormone therapy for prostate cancer. So just to give you an idea of kind of how my journey evolved into exercise oncology. And at OHSU, I am a professor here in the Division of Oncological Sciences. I oversee a division called Cancer Population Sciences, and I also co-lead the Cancer Prevention and Control Program for the NIGHT. So that's a scientific portfolio of work in cancer prevention and control, and we have a very strong cancer survivorship program, of which I oversee and am a part of. And I also co-direct a program called the NIGHT Community Partnership Program, which is a granting program funded by the NIGHT that was actually a result of a huge philanthropic effort in partnership with Phil Knight from Nike to raise funds for the Cancer Center. And a portion of those were allocated to go back to the community. So we actually run a granting program to put funds back to the community to address cancer-related issues that they're concerned about. So just a little bit about that. My overall vision for my research program is to use exercise as medicine for cancer. I work in a cancer center that is very strong, and very focused on precision medicine and on developing therapeutic approaches. For cancer, one thing that we know we have to keep in mind, though, even with those therapeutic advances, is that, aging is a part of cancer. And so as those therapeutic strategies are being developed, people like me also have their eyes on, how are they altering the trajectory of someone's aging? What other additional problems may they be incurring that actually create additional health problems? So a large proportion of people with cancer, as you guys know, are older. A lot of people are concerned about their quality of life, and if treatment are going to compromise their quality of life, then that makes it difficult in terms of decision making. And some people would just avoid treatment altogether if it significantly affects their quality of life. And so we know that exercise has the potential to control disease progression and has the potential to improve treatment side effects, but it is not yet part of standard care. And a lot of people struggle to become active enough to know what to do to feel like they're exercising safely. And so this is part of my vision, is to develop a strong enough evidence base and contribute to the evidence so that exercise does become part of standard care for people with cancer. So that's really the ultimate goal of the work that I'm doing. This is the model that I work from as a scientist. And I'll walk you through it ever so briefly, but, in addition to the changes that people are facing from aging, as well as other conditions besides cancer, that we know cancer treatment on top of those conditions, either accelerates functional declines or adds new problems that accelerate functional declines, and that ultimately they could result in additional health problems besides cancer. So I'm very focused on musculoskeletal health. I'm concerned about the impact of cancer treatment on accelerating a condition we call frailty, that leads to falls, combined with bone loss can cause fractures, and those end up creating significant morbidity and mortality. Of course, I'm also concerned about the effect of disease and treatment, and how it may accelerate cancer progression. And then I'm becoming increasingly interested also in mental health and making sure that what we can do, and if it has the potential to improve mental health, that we're able to look at that. So this is kind of the working model that we work through. Like I mentioned, I'm pretty focused on musculoskeletal outcomes. So I'm interested in disrupting this pathway through exercise and making sure that quality of life is high as possible for as long as possible. The approach that I use, this is a lot of the pathway that takes us to a clinical trial. So, we do some observation studies, we identify the problem, we develop an intervention, and we run a clinical trial. So a lot of what I do, besides just clinical trials, is also focus on trying to understand the problems enough so that I know what the right intervention is. So back to this concept of specificity, if I'm trying to prevent falls or I'm trying to improve bone health, I don't necessarily put everybody on the same type of exercise program. I want to manipulate that exercise program in a way that I know it can specifically address the problem that I'm trying to solve. So then once we have understood what the problem is and we think that we've designed the right intervention, we run a clinical trial to test the efficacy of that approach. I will say that oftentimes this leads us back to observation, and then we run through this cycle again. But this is generally describes a lot of the work that I do in my approach to clinical trials development. In the case of prostate cancer, one area that I've been working on for a long time is the impact of cancer treatment on accelerating aging. So these are kind of the typical changes that will accompany androgen deprivation therapy. It changes body composition, causes extreme fatigue. It can result in neuromuscular changes that cause slowness or weakness, instability. And then it can also make it really difficult for people to stay active enough. So I know that this is a very engaged group, and a lot of you work very hard on your exercise program, but a lot of men are not able to do that or have a lot of difficulty. And then that only kind of compounds this trajectory that can lead to either longer term kind of late effects that we know are increased from ADT, like cardiovascular disease, diabetes, frailty, and loss of independence. So we've done some descriptive work, like I mentioned before, trying to understand the impact of treatments like ADT on frailty, which is this kind of accelerated aging phenotype. We did a study as part of trying to get a grant funded to convince reviewers that there were kind of persistent and troubling problems from ADT and that accelerated aging. We did a study where we kind of characterized this frailty phenotype that we've also combined with obesity, because together they end up causing greater problems than either condition alone. And we hypothesized that men who were currently on ADT would have the worst frailty profiles. Men who were on ADT for a shorter period of time and were no longer taking it might have intermediate profiles, and that men who'd never received hormone therapy would have kind of the best profiles. What we observed is a little bit different than what we thought. It turns out that whether or not you're currently taking ADT or you've had it in the past, that the prevalence of frailty is quite high, and it's not that different. So the recovery from ADT, at least in this domain, we're not seeing it. And so that means, that there are a lot of men who've been exposed to ADT throughout the course of their prostate cancer treatment that are now at risk for this condition. We've done some descriptive work. Brad asked me to talk about wearables. This group might be interested in wearables. We do use wearables in our work, increasingly so, not necessarily as an intervention, but in part to help us characterize some of the problems that we're trying to better understand. We've been doing some work lately with this wearable called a smart sock that you can see on the left. It's there are wireless sensors in the sock on the top of the foot and along the ankle. And we have men wear these for 3 to 7 days in their home. And it measures kind of what we call free living mobility, and gives us a sense of how men are really moving in their own environment, not when we ask them to walk down a hallway, which, right, everybody tries to do their best. So we use these smart socks to try and characterize and see whether or not what we're observing with our first study, is kind of persisting, and what we see when men are in the home. So we use these smart socks. We measured this construct called double support. It's how much time that you spend with both feet on the ground. And it's an indicator of a worsening gait pattern. Usually if you ambulate really well and freely, you have a lot of time on one foot. When you start to slow down, you spend more time with 2 feet on the ground, so kind of the shuffle stutter step. And what we saw when we use these instruments is that men who, again, were exposed to ADT were really kind of had gait patterns that were similar to much older men and worse than men who were age matched. So again, more to this proof of concept that we're seeing this accelerated aging phenotype with treatment. So if we go back to the model, what we're trying to do really is use targeted exercise to interrupt this trajectory so that we delay or prevent these downstream consequences of hormone therapy. So I'm going to walk you through just a couple of the trials that I do, and then we can get into a discussion. So in addition to those mobility issues, I think you're all familiar with the adverse effects of hormone therapy on bone health and on bone strength and an increased risk of fractures. So back to what I was originally talking about, my work at Oregon State University, some of the first studies that we did in prostate cancer were to try and use this type of exercise program that we had developed that we found to be effective at improving bone health and improving functioning in people without cancer, and whether or not it could effectively be a countermeasure to individuals who are experiencing those changes because of their treatment. So this was a little bit, it wasn't a no-brainer in terms of whether or not this would work for a couple of reasons. The program was effective at addressing age-related changes. It had not been tested in whether or not it could be an effective enough countermeasure. Like, was it strong enough to counter kind of the powerful effect of something like hormone deprivation therapy, where, testosterone and estrogen levels are basically wiped out. It might be that exercise just isn't strong enough and it takes more of a pharmacologic approach. So this was the reason why we wanted to test whether or not exercise could be an effective countermeasure. This is a pretty rigorous program, so we also had to determine whether or not it was tolerable. And if it wasn't tolerable, the load we thought, or the dose we thought would be effective, was the dose that was received still effective? So this was the premise for a study that we had funded by the Lance Armstrong Foundation back when it was the Lance Armstrong Foundation. So that's been a while now. And we tested a very specific bone loading program where we selected specific exercises that load the spine and the hip in ways that we think are osteogenic or bone loading. We add an impact component of jumping exercise that generates ground reaction forces that we think also load the skeleton in a way that causes it to adapt. So this is kind of what the training program looked like. You can see it may not look like the training program that you guys do, but it's because it was very selective for these exercises, and those had been shown to be effective in other populations. We did have, this was a year-long study that we ran in about 80 men who were currently on ADT for prostate cancer. This was conducted at OHSU 3 times a week, obviously way pre-pandemic. And we had decent retention, decent adherence, and decent tolerance to training. And what we found was that with this exercise program, we were able to completely stop bone loss at the spine. So men who were in a control group continued to lose bone at a steady rate, as we would expected, but the exercise program stopped that entirely. We did not have as much of an effect at the hip. And we think that's because we were very conservative in our jumping program, and we would increase the dose next time. But we started to see a little bit of a benefit, and it's possible the training program wasn't long enough. So this is kind of the first type of work that we did in prostate cancer. In that same study, you can see men here in the upper left in our trial. They wear a weighted vest to weight their lower body exercises. We do a more functional resistance training program because, we are also interested in not just preventing bone loss, but improving functioning and reducing fall risk. So we don't put people in machines. Machines unweight you. And even though you can get pretty strong on a machine from a bone loading perspective, it removes gravitational forces. So we didn't want to do that. We also try and create improvements in functioning by using functional movement patterns in the exercise program. So instead of putting you in a leg extension machine, we would have you do a squat or a lunge with a weighted vest to increase the intensity. Because this is the type of way that you move in your day-to-day life. You don't sit in a chair and extend your leg and accomplish anything. But you might, lunge forward when you're gardening or working or in an activity. And so we, again, are specific in the way that we apply exercise that way. This exercise program had additional benefits besides the impact on bone. So we were able to reduce self-reported disability in men, which means that men were able to do more activities without any assistance. They were able to fully engage in the activities that are meaningful to them. We also found a metabolic impact of resistance training. So, as you're thinking about, do I do aerobic exercise or do I do strengthening exercise? Resistance exercise has a good cardiovascular and metabolic impact. We were able to observe reductions in insulin, circulating insulin levels, and reductions in body fat with this resistance training program. So just to give you an idea of kind of the broader benefits achieved by the single program. So I'm going to move on to what I think is probably of interest to this group, and kind of the other really important question that we're still trying to answer is whether or not exercise can help improve survival. There are some epidemiologic data that suggest an inverse relationship between physical activity and prostate cancer mortality. Ever since some of those epidemiologic findings have come out, everyone's been very eager to design the randomized controlled trial to test that observation. The Movember Foundation, I think it was, I think 2016 started what was called GAP4, also called interval trial, that was a large worldwide randomized controlled, multi-site randomized controlled trial to test whether or not a pretty rigorous exercise program could improve survival as an endpoint in men with advanced prostate cancer. We have been a site for the Movember trial ever since it started. The premise of Movember is really to think about all of the potential physiologic, metabolic improvements or adaptations that happen with exercise that should also be anti-tumorigenic. And, you know, a lot of this is kind of based around lowering inflammation levels. So Movember, the study's been ongoing for a long time. I am sad to tell you that it was stopped prematurely because of a lack of enrollment. The original goal was 1,000 participants. I don't know what the final enrollment ended up being, but due to COVID and due to just some difficulties with enrolling patients on a pretty intense exercise program and a pretty intense clinical trial, it was closed. They're currently in the process of gathering all of the data from multiple sites and trying to, you know, find what they can and maybe look at their secondary endpoint. So I just want to let you know that we participated in that program. Back to the current work that we're currently doing. So on the theme of musculoskeletal health, our first trials were really focused on using exercise in a specific way to improve bone health. In the interim, we became very interested also in trying to figure out whether or not the elevated fractures from ADT, you know, we know bone weakness is probably playing a part, but as someone who's studied fractures for most of her life, I can tell you that very few fractures are truly osteoporotic fractures, meaning that the bone breaks first and then the person falls down. On the other hand, most fractures are associated with some type of trauma, and it's oftentimes a fall. So we also did some work that showed that ADT increased the risk of falls in men with prostate cancer. So that led us to design a trial called the Get Fit Prostate trial. And this is a fall prevention trial. We are comparing two types of exercise that have been shown to prevent falls that are related to age, not cancer treatment, to see whether or not they might also be effective programs at reducing fall risk due to ADT. So Get Fit Prostate is comparing Tai Chi or Tai Chi Quan, which is aimed at improving postural control. It's a very effective program at preventing age-related falls in older adults. And we're comparing that to a strength training program, which is also known to prevent falls, but through a different mechanism. And we compare that to a placebo control exercise group. And this trial aimed to improve or reduce falls in 360 men exposed to ADT. Our trial started in 2019. Obviously, we got hit by COVID in a bad way. We are a exercise study in older adults with cancer. And so we deliver group exercise. And And we were among the first types of human subjects research to get fully shut down from COVID due to risk of exposure. We converted everything online. So you can see my group down here on the right, doing their Tai Chi online. We did that within 72 hours of shutting down in-person classes. So on the left is Friday, on the right is Monday. So we've been online ever since. Interestingly, our retention and our adherence rates are just as high, if not higher, now that we've moved online. The efficacy looks to be similar between online and in-person exercise, and the safety profiles are the same. So the other advantage that we've gained from moving online is we've spread our program across the state of Oregon. So if you know where Portland is, it's kind of in the green shaded area on the map. The yellow areas represent counties where our participants now reside. If you recognize your state on the lower right, that's Connecticut. So we've actually had people find us on the internet and ask to participate. So there's really nothing that stops us from offering these programs to anyone really across the globe, except for time differences.
Question, Kerri.
Yeah.
So is this a trial that has a start and a stop enrollment date, or do you take rolling enrollment so that, I mean, you have to manage kind of the data of, how and when people enrolled and what's the effect. So can you comment on that?
Yeah, yes. Excellent question. I was just about to get there. These are 6-month intervention programs. They have a designated start and stop time. We enroll about 50 to 60 men at a time. We start their exercise, we randomize them. We start their exercise programs. They train as a group. They end as a group. And then we start all over again. So we've had 9 groups of men participate so far. I'm happy and sad to say that we graduated our last group last Friday. So we converted the trial. Online, we enrolled 328 men in the program. That was 91% of our target, even with COVID. This program is inclusive of men with bone mets, whereas a lot of trials are not, out of safety concerns. And the trial is going to complete. So we finished our last exercise class last Friday.
Did we lose Kerri, or am I the one who's?
No, I don't hear her either.
Lost her too.
She froze.
Hopefully she'll come back. Maybe, what's the weather like in Portland?
The weather is overcast, but bright. Actually, it's just, I can see out my window into the neighborhood, and it's actually sunny a little bit right now.
Okay, well, so it's not a power outage or anything like that.
No.
No.
So Rick's taking a page from Russ's book and he's exercising while watching the video. All right.
Yeah, I'm inspired. Brian, you already hit the gym. I didn't. I barely rolled out of bed for this meeting, so I'm doing push-ups and lunges.
I was going to ask us to use the time while Kerri's not here. Kevin, could you tell us about your interaction with Kerri? So Kevin has participated in one of these trials.
Well, I was in the worldwide trial that she talked about that got shut down, but part of it that distressed Kerri, that was a trial that had a control group and a intervention group, and I was randomized into the control group. I did hire a trainer and they gave a little support, but because their specific regimen was proprietary, you sort of had to, so it was a strength and resistance kind of thing. And I went to the gym and used machines and all that. And until I got totally wiped out last year on that trial, my exercise program is pretty meager right now. the thing that I was anxious for Kerri to talk about when we talked with her, Brad, is she seemed to indicate that they learned a lot from doing things online where they were forced into that from COVID, and that there could be some things, because she's not a big fan of randomized trials. She knows people like us, we want the intervention. We don't want to be in the other group. And I'm sort of anxious to hear if she's going to be offering opportunities for people like us to enroll in something, you know, maybe a little more personalized thing like an Apple Fitness or whatever, where you're doing a program online. But
I think she mentioned when we spoke to her that she has that as a side gig, so hopefully she'll come to that when she.
well, or that she sort of spun that off out of OHS, you might say,
Right.
to a nonprofit, but still was trying to promote that.
Right, like sort of her academic work sort of limits her ability to do something that's more of a steady thing, a service like that, but she was going to set it up to make it available.
Right. And I don't know if she was beginning to, the Get Fit Prostate had 3 different things, balance, strength, whatever. I didn't choose that because I would have had to drive in a half an hour for a short class a couple of times a week. So I went for the other trial, but I thought that was maybe going to open up. And it almost sounded like that was wrapping up in 2023. So she probably has more to tell us about that.
I'm curious if I guess she's coming back. Yeah.
There we go.
I dropped, right?
Yes, yes. So we took advantage of the time you were off, Kerri, just so you know. I had Kevin share his experience of working with you on the trial where he was randomized to the control group. But anyway, so there's some questions that are lurking in the background about how people can access some of the things you have. So anyway, but go back to your slides. I imagine you're close to being finished.
I'm close to be finished. I could do it verbally instead of having to mess with PowerPoint.
Yeah, that'd be
Why
fine.
don't you, since we have only 20 minutes left, please?
Yeah. So where I was ending was just to share with you some of the clinical guidelines that I've been privileged to be a part of, and what we hope are going to help move exercise into standard of care. So a lot of the evidence base and the work that we've been doing, we're glad have contributed to some new clinical guidelines. So in 2019, we reissued the exercise guidelines for people with cancer through the American College of Sports Medicine. Just recently in 2021, we issued exercise guidelines for people with bone metastases who tend to get left out of a lot of the exercise recommendations out of fears around safety. And then I also just wrote, and I'm glad to share with this group, some brief clinical guidelines for providers to prescribe exercise for men with prostate cancer. So I was just sharing with you kind of what we're trying to put forward in terms of clinical guidance that we believe will be the impetus for now starting to require that exercise get moved into standard of care. I think, what's holding us up right now are some of the data that speak to third-party payers in terms of if they fund exercise and support exercise in clinical care, what is the clinical benefit and what is the benefit to the healthcare system in return for that. And so that's where our field is doing more work to make sure that we're including endpoints that are meaningful to those parties. I think they're meaningful in general, but they won't fund exercise because it helps reduce your fatigue. They will fund exercise if it helps keep you out of the hospital, and if it helps reduce the cost of your medical care. And so a lot of the trials are also now starting to collect those endpoints so that we're more effective, I think, at our overall goal.
Okay, so let me ask just a couple big picture questions and then turn it over, because I'm sure the group wants very practical advice on what you recommend they should do based on your research. I'm very intrigued by the notion of exercise as medicine. We've heard food as medicine, but this is the first time I've ever heard exercise as medicine. And we had a session with Nigel Brockton of the American Association for Cancer Research, who said, we spend a lot of time on nutrition. Why do we do that? Is it more important than exercise? And he said, no, it's just that it's more complex. So how would you, just from the big picture perspective, if you had a pie, I have this image of a pie chart. There are things we do with therapies, there's things we can do with food and nutrition, there's things we can do with exercise, maybe sleep or meditation or things. If you had a full wheel and the effects it can have on someone's care, which is, I think, the way everyone here looks at it, how would you rate exercise in that pie chart in terms of its potential impact on your disease progression?
On disease, well, I would add another pie chart in terms of quality of life on that too. But I would say in terms of, so what we have seen from the epidemiologic data is potentially a 50% reduction in prostate cancer specific mortality and prostate cancer recurrence. So that's pretty big effect.
It's pretty big.
And right, it's
Amazing.
more powerful than chemo. It's probably more powerful than a lot of the current treatments.
Okay.
Is
Russ?
that
Just
data-
real quickly. I've talked to my MO extensively about exercise, and she feels is the most important thing that we can do for ourselves.
Yeah,
Prostate
mean,
cancer.
I would agree. I think what makes me sad then is that you don't have a warm handoff to
Yes.
someone to tell you what to do and to put you in a program. So what we need is like cardiac rehab, right? So that you've got phase 1 cancer rehab, the time you get diagnosed, right? Phase 2, you're coming in and out a little bit to the cancer center. And then phase 3, you're out in the community, and it's lifelong. Like, you don't necessarily graduate. You just might move on to another setting. So I think that's the gap that we're needing to fill, that we just simply can't fill fast enough. Because I think not every, a lot of people struggle with knowing what to do.
And so if you just had my last question, then I'll turn it over, but just a simple summary of advice, we trust that the research is backing up, the evidence is backing up whatever you're about to say, but, basically you don't have to prove it to us, but what would you do? I always love this phrasing. What would you do if you were us? That is, what advice would you have for any one of the advanced prostate cancer patients, most of whom have been on ADT, as you've been discussing?
From an exercise programming standpoint, I think you should work towards aerobic exercise 3 to 5 days a week, 30 to 60 minutes at a time, resistance training 2 to 3 days a week, and flexibility, mobility every day. That's a lot. And what I'm saying isn't any different than the public health guidelines. But each one of those have different benefits. And so an ideal program would contain those different modalities. And those are the doses in which they are effective, right?
I'm sorry, did you mention when you mentioned flexibility, did you mention any stretching?
That's what I mean by flexibility.
Okay.
Yeah, flexibility, mobility. You can call it yoga. Yoga's got a little bit of other stuff in it too, right? It's got some strengthening, it's got some stability exercises. But flexibility meaning stretching. And I'm getting older too, and I like in order for you to do the other two types of exercise, in order for you to strength train, in order for you to do your aerobic exercise and to function in your day-to-day environment, like do the things you need to do, I think you need range of motion and you need mobility. And if you don't have those, and you do a squat, for example, and you have poor ankle flexibility and poor hip mobility, you're going to do the squat wrong and you're going to get hurt. And so it's like the flexibility provides that foundation for movement. And it doesn't take a lot, it takes, we recommend about 15 minutes every day. So, that's a morning stretching routine or an evening stretching routine that gives you that foundation for movement.
Curious, Mike Yancey, I got a question.
You don't know how to
for you.
stretch.
I've got significant bone mass, and particularly in my vertebrae, clear up and down my spine. So even though I'm able to do some weight work, my doctors have pounded it in my head that they don't want to load my spine up at all. So that limits what I can do. Don't know if you have any, because they're really afraid of a vertebrae just crushing. So I don't know if you have any suggestions, recommendations, etc.
Yeah, I do. And that's always difficult. And I think, in the absence of having super clear guidelines, everyone's going to err on the side of caution. And so that's what they're doing, right? They're erring on the side of caution. Because we don't know, even from the osteoporosis field, right, where you've got weakened bone and we're trying to be careful. I think we still have never been able to do the right study to show if you do a squat with this level of bone meds, it is risky. We just don't know that. So my advice tends to be this. I think body weight exercises. So if you're doing unloaded exercise and your form is correct, then I think the risk is relatively low. As you start to increase weight, or if you start doing things incorrectly, the risk is going to increase. The general guidelines that we use for exercise for people who have osteoporosis, right? I mean, the other things you should avoid are highly dynamic, rapid loading kind of exercises, twisting exercises, hyperflexion, hyperextension. So any extreme loading on the bone. I would also be careful of exercises where the weights are away from the midline of your body. Right. So doing crunches with a barbell up here isn't no good. Because the further away you move the weight from your midline, the more pressure it puts on your spine. Right. So the classic osteoporotic fracture is an osteoporotic woman leans over to get the turkey out of her oven and holds the turkey and fractures her spine. So that's like picking a load up, heavy load that's way away from the midline of your body. It's almost like if anyone's had to go through NIOSH lifting mechanics for how do you safely lift a load, for occupational safety, it's the same kind of guidelines, right? You want to keep things close. Does that help, Mike?
Yeah, most of what I've been doing so far is most of my weight work in the upper body, at least, has been by laying down on the bench and doing that kind of work. And of course, then sometimes I will also lean over that bench, but I will rest my elbow on the bench to pick up the load so that my spine's not picking it up. And then of course, do some curls or whatever from that perspective. So that's most of what I've been doing. And one more question I had for you, I'll let somebody else jump on here. You mentioned aerobic, and of course, I love to walk, but unfortunately, recently I've had significant hip pain, so that's kind of put me on the sideline there. In your opinion, I swim 40-45 minutes a day when I get a chance. Is that would you consider that an aerobic exercise? Yeah. Okay.
Absolutely. Yeah, 100%. So anything aerobic exercise is if you're using the large muscle groups in a repetitive way, and it's not against high loads. So
thank you.
Swimming, cross country skiing, the Versa climber, the elliptical trainers, those are all, kind of like a whole body aerobic kind of movement.
Thank you. Appreciate that.
Yeah, you bet.
So you mentioned that there are some guidelines available. Can you share the links for those guidelines, especially for the bone mets? I'm actually pretty much in Mike's situation, also very similar condition and issues. And recently, because of his spinal cord compression, I've developed, more neurological and issues as well. So I think some kind of published guidelines that you can share would really help. And what's kind of the best way to find a trainer, who's actually is certified in this? We've seen a few links in the past, but I would like to kind of pick your brain on best way to find a trainer.
Yeah, I'm happy to share those guidelines. And they don't necessarily specifically prescribe exercise. So they are around, clinical guidance, like, can you send a patient out to community exercise if they've got extensive bone mets, or do they really need more like one-on-one training? So it's a little bit more like that than it is like peppered with sort of the same type of guidance that I just gave Mike. So I'm also happy to talk to anybody on a separate call or have an email discussion, because that is tricky. The one thing I forgot to say to Mike that I'll also say to others is, and again, this is in my opinion, knowing bone adapts to its habitual stresses and it gets strong in those ways. So the types of exercise that you're doing, Mike, it's probably accustomed to. And it's really, if you do something different or kind of excessive, that puts the bone at risk. So I just say that because the things that you're already doing, if you're tolerating that well, you're probably going to be able to tolerate it. So that tends to be the way that bone behaves. In terms of getting a trainer, and this may be what people have told you, there is a certification through the American College of Sports Medicine for cancer exercise trainers, so that individual has advanced education and experience working with people with cancer. And so there is a directory for cancer exercise trainers through the American College of Sports Medicine that I will send you guys the link to. And I believe you can search by zip code, and then you could reach out and contact those individuals, who hopefully they would be available. I will say that we don't have enough of them across the country to be available enough to all the people who need it. But that might be one place, for you to be able to find someone.
Are there online group classes? Maybe if you can share some information about that, that would be helpful.
I can share that too. So we have a resource list that we give to our participants once they finish a trial. Kevin, you might have gotten, I don't think we were able to give you yours yet, but, and so I'll look for ones that are not local to Oregon. I will tell you that and I'm not on here necessarily to plug it, but one of the things that we have done from our research programs due to demand is I now have a nonprofit that's called Fit Together. And we deliver our evidence-based exercise programs in a community setting because people from our trials didn't want to stop. So we ended up creating a nonprofit. It is supervised group exercise classes for people with cancer and their partners. So we also, because our work extends to partners, we also allow partners to participate. So I'll send you guys the link to that. We have yoga classes. Someone put in the chat, I don't know how to stretch. I have a yoga class that I think could help you. I have, Rick, was that you, Rick?
Yes.
Yeah, I have lots of YouTube and online videos. I prefer to know you before just sending out a video to you to follow, but we also have stretching routines that we have created that we're still working on publishing to our OHSU website. But let's continue to talk about that. And the Fit Together classes would also be a group class that you could take if you were interested in that.
Can we reach out via email individually, or how?
Absolutely. Yeah.
Okay.
I have like 20 or 30 questions. So what is your email address? I don't want to take up all your time. We're almost about done here.
Yeah, it's totally,
Yeah.
I don't mind staying on. But I'm also glad to just get on a separate chat. Let me put my information.
I would, if you don't mind staying on for a few minutes, that'd be fun. That'd
Sure.
be great.
Yeah, it's up to
Really.
you guys what you want to do.
Please proceed. Yeah, we
Yeah.
typically, we sort of finish the formal part if this is the 1 hour mark here, but if you have time, Kerri, we often stay in chat more informally. I will keep the recording going for the next 10 minutes or so, because I'm sure that Russ's questions are going to be relevant to everyone. Go ahead, Russ.
Fire away.
So with ADT, have you heard of transdermal estrogen therapy? Either in addition to ADT as a low dose replacement, or like the patch trial in place of ADT, or in place of the standard ADT drugs. I don't want to say in place of ADT because it actually has ADT.
Yes.
And what do you think? What do you think about the bone loss mitigation results that have been found through the patch trial and other trials, other studies?
I mean, that's even been shown in like postmenopausal women, is that you don't need this, say, like just a low dose of estrogen is enough to have this bone preserving effect. So
do you think that's something that I actually did the patch trial myself 4 or 5 years ago, or their high dose estrogen, and now when I go on, I'm on something called bipolar androgen therapy, and when I go on my low cycles, ADT cycles, if you will, I do like a very low dose estrogen replacement. What do you think that should be standard for guys to do that? I've spoken with a number of MOs and urologists about it, and when it comes down to it, I say, does increasing estrogen or adding a little estrogen, does it affect ADT, low testosterone? Their answer is always either crickets or no, I don't think so. Done.
I'm going to go
In my
crickets because I'm not a clinician, so I'm going to avoid any comments there other than,
Okay.
I think like from this, yeah, I always get a little bit wary of doing that. But from a bone preservation standpoint, I think some of the other that's been able, you don't need a high dose of estrogen in order to have some bone preserving impact. I would say the other thing for those of you worried about fractures, if you don't fall, like you're probably going to avoid a fracture. So, I mean, the other and I don't mean stop moving because you're afraid of falling down. There's kind of this U-shaped curve that we see that not enough exercise increases your fall risk. When you're super active, your fall risk goes up too, because you're just taking more chances. So it's not because too much exercise increases, it's a environmental like hazard more than anything. So, but I would also just think about keeping yourself strong and working on balance control, and being environmentally aware of the potential fall hazards, that exist in your environment, and taking care of those. Low lighting, small dogs, rugs, and seemingly innocuous things that can be dangerous. So I think that's the other thing from a fracture prevention standpoint, that we know exercise is the only way to stop a fall. There's no drug for that.
When I was first diagnosed and started androgen deprivation therapy, my oncologist actually screened trainers who had, I think, a certification that you were talking about. And I actually worked with one virtually for about a year and a half. I kind of learned all the routines and try to carry that on, although it is nice to have a cheerleader, but.
Yeah.
So I just put this in the chat with the address or with the website. So it may be a place to start to check that out.
That's great. I'll look at that myself.
Russ, did you have more questions? Because then we'll go to Rick.
Yeah. I was wondering about the research or what you think of whole body vibration plates. I've seen a little bit of research about it. It makes a little bit of sense to me when I'm working out. I jump on either do a whole body vibration plate in my rest periods or do an elliptical cycle.
It's so interesting you bring
What do
that
you
up.
think about
So yeah, I used to have a platform. I used to have 2 of those. And so I don't know for those of you guys who aren't familiar with this, whole body vibration is a high frequency, low amplitude platform. It's like a shaker plate. Think about it. That was originally, I don't know if you know the origin of that, but it was originally developed out at SUNY Stony Brook by a skeletal physiologist as a way to stop zero gravity induced bone loss, because you can't use, like, weights don't matter in space. So it's the things they have to do to keep astronauts from losing bone are crazy. They've got to like strap them to their treadmills and use these really heavy bungee cords and things. So anyways, they developed kind of this opposite approach. So high frequency, low amplitude is going to improve the bone. He did a bunch of experiments in turkeys. The guy's been on Time magazine. It worked. From that perspective, it's been slow on the uptake in the human trials, because I think you can't, there's now a worry that too much vibration could be harmful. So I think it's had a difficult time making it into the medical world. It has made it into the performance world. So you'll see these plates in training rooms, you'll see them in gyms. From a scientific standpoint, the evidence is kind of like so. Some trials show that there's a benefit, other trials show there's not. I had a platform, I was able to see some benefit really around bone loss. I'm using it now more for peripheral neuropathy, and I know a lot of you guys don't get, neuropathy. It can't hurt. I don't know from a scientific standpoint if I can say really confidently that it's doing a whole lot more.
That's kind of my take on it. The research is pretty sketchy, in my opinion. I'm not a turkey. I'm not a rodent. So
you don't want to shake till your eyeballs come out of your head, but I think that.
I heard one guy said that this is kind of off topic, but he said he was on he had a brain aneurysm or something on a whole body vibration plate. And he said, my teeth were chattering first. I was shaking so hard and my jaws were hurting. And I'm thinking, okay, dummy, get off the plate.
Off the plate. Yeah,
this
that's
is Darwinism. I don't know. I'm a little lost there when I heard that.
I haven't had success getting a trial funded with the type of vibration I think you're talking about. I've moved more toward a very low vibration. It's almost like a hum.
Very low, as in what type of frequency are you using? Curious.
God, I'd have to look back and see like what the hertz are on that. I can definitely send it to you, but
okay.
It's been hard to get that because of occupational vibration loads and concerns over that. I would say when you do use it, make sure that you're kind of in a semi loaded position. So if you're squatting on it, you don't stand straight legged and just let it vibrate, because there's nothing to dampen the vibration. So if you're in a semi-loaded position, I don't know if you're doing push-ups on it. I wouldn't go to straight arm push-ups. I wouldn't go to full extension if you're doing squats on it. I'd always stay like a little bit loaded, if that makes sense.
Okay. Yeah, it does. Did NASA also do some research on PEMF? pulse electromagnetic frequency
I don't
for
know.
bone loss. Okay.
That I'm not sure about. Yeah.
Okay. What do you think of the different vitamins and supplements, calcium, DEK, boron, phosphorus, etc.?
I'll only go so far to talk about what I know. So calcium and vitamin D. I think, for women who are hormone deplete, so postmenopausal women, the recommendation is about 1,500 milligrams of calcium a day. Men tend to not, for men, it's 1,000 because we don't account for hypoestrogenism or low testosterone. So I would go with the 1,500 milligrams a day. And you should break up your doses throughout the day. So the gut can only absorb so much calcium and then it's just going to pee it out. So about 500 milligram doses is the maximum that can be absorbed at any given time. So if you're doing 1,500, I would do like a dose in the morning, breakfast, lunch, and dinner, basically. Calcium citrate tends to be the most absorbable, followed by calcium carbonate. So like oyster shell, calcium, not as good as like Citracal or some of these other supplements that are on the market. Vitamin D, it depends on where you live. So those of us in Oregon, we don't get vitamin D in the wintertime. So you might benefit from a supplement.
How much? 500 or 1,000?
Probably 1,000.
Maybe 500 trees. I'm thinking, well, does it depend on kind of, it seems to me kind of, we're an ADT, we're kind of like post-menopausal women. When we're not an ADT, we're not necessarily, if our testosterone is recovered and estrogen is recovered with it.
But I mean, from a
So
calcium
maybe
standpoint, the worst that's going to happen is you'll excrete
get
it
rid
in
of
the
it,
urine.
eliminate it.
Yeah. Unless you're a stone former and then, you've got to, but hopefully then you're under the care of your urologist.
Go ahead, Brian.
Yeah, I'm concerned about cardiovascular health. So, I've been on ADT for over 6 years. And so I'm curious if you have any sort of bell curves that show over time how the risk of some type of cardiac event increases the longer that you're on ADT. I mean,
yeah, that's a good
for me,
question.
I've got a Fitbit. I'm looking at, the zones that I'm in when I'm running or when I'm on the Peloton or whatever, any kind of exercise. And I noticed that I seem to be in like zone 5 a whole lot more than I should be. And I mean, it could be because I'm just, coming off of some surgeries and whatnot, but I'm a little worried about, having a cardiac event because I've been on ADT for so long. And my Fitbit is telling me that I'm overheating my engine.
You're kind of, yeah. I mean, it's a good question. I don't know the answer to the, kind of long to that trajectory of risk. But now I'm really curious. So I will look and see what I can find. I would say the best thing to do if you're concerned is get a graded exercise test.
Like a functional test, like hop on a treadmill.
Yeah.
Yeah. I did that years ago. I was fine, but that was probably 2-3 years ago. So I guess I could do it again.
You could. And then, I mean, what's nice is if you do that in a, where are you, Brian?
San Diego.
Oh, you got access up the wazoo down there.
Yeah.
But if you do it in an exercise science lab or something, then they can actually like look at your heart rate response to your VO2, to your oxygen consumption, and kind of like get an idea of what your training zones are and like what is your cardio, like when you're in your zone 5, whatever heart rates those are for you, are they seeing any cardiac arrhythmias? Is anything popping up? Right. So that then you sort of get an idea. Well, you get the hopefully all clear, but then you kind of also get the idea if you end up having some symptoms, like what's your symptom limited exercise and what's the right zone for you. But if you're asymptomatic when you're in those zones, I would, and again, not being a cardiologist, but from an exercise science perspective, I don't necessarily know that you're at any more risk than when you're at a lower zone.
Yeah. So given the fact that so many people now have Fitbits and wearables, there's all this data, right? I got truckloads of data. Certainly I could go in and have a functional test, but it seems to me that it would be far more insightful if I could upload my cardiovascular data to some site
Yeah.
that would tell me where I sit on that bell curve. Is anybody working on that?
Not that, I mean, I know exactly what you're talking about, and I know there's a lot of interest in that. Not that I am aware of. It doesn't mean that it's not happening potentially out of the oncology context.
Okay. Well, I think we've got Mike Snyder coming on in April. Maybe he can help us.
Oh yeah, he's the big guy. He's the guy down in Silicon Valley, right?
Yeah.
Fitbits. Yeah.
Yeah. Okay.
Just in terms of the facilitation, I want Rick to ask his question about high intensity versus long, slow. And then I'm going to stop the recording. We keep talking, but I wanted to get that question in before we stop recording.
Yeah, I used to believe, and I used to get my aerobic exercise with like either swimming. I'd swim a mile, but I would swim it all at once, no bursts, jug out. We used to call it LSD, long, slow distance, when I trained, when I ran. Then I heard about HIIT. Okay, HIIT, forget about that. And so I haven't even done a mile time lately since I learned about HIIT. It's just like 30 seconds hard, as hard to recover, repeat. And then I got some guidance from the Block Center and us, Integrative Oncology Center, which said 30 seconds as hard as you can, 30 seconds rest, repeat 3 times, then take a little rest, and then repeat that 3 times, a 3 times 3 kind of approach. So I kind of stopped long, slow distance for HIIT. Is that a good plan?
Yeah, it's a good, if anyone's not quite sure what we're talking about, this is that when you train for, like, training for a marathon is a really good example, and you've got long, slow distance, right? You're like 15-mile runs, 20-mile runs that you do on the weekend. And then you've got interval training, which is what you're talking about, the high intensity interval training that's kind of boosting your fitness. So they both serve their purpose. But right now there's really a movement toward using HIIT as a efficient way to improve fitness, cardiovascular fitness, and the data are pretty strong. So it's like interval training. If you guys were runners, it was called fartlek training, but you do these bursts of high intensity, kind of like 90 to 100% of your max. And then it's followed by a recovery period, walking or jogging. And then you do another short burst. So in terms of improving fitness, like cardiovascular fitness in an efficient, time efficient way, HIIT is a really good program. If you're trying to improve muscle endurance because you want to run a marathon or you want to do a long cycling event, you gotta run for a long time, and you gotta stay on your bike for a long time in order to develop that level of specificity. So again, it's this specificity of training. It depends on the outcome. So if you're interested in bolstering your fitness and the metabolic adaptations, I think HIIT is a nice, efficient way to do it because it doesn't take much time.